Hello, this is Kumar Madassery, one of the interventional radiologists at Rush Medical Center in Chicago, Illinois, and Rush Oak Park Hospital in Oak Park, Illinois. Thank you for joining me for this topic, which we're going to talk about the ATTRACT trial, which has been talked about before in terms of the trial itself. But the question is, where do we go from what we know about the study and the results of it and how it's being employed in practice presently? Next slide is a disclosure slide. Moving on, the goal here is we're going to talk about very briefly on post-thrombotic syndrome, which has been talked about in extent for many people. However, just to briefly overview it, discuss the ATTRACT trial, interpret the trial itself, and then what do we know from it and where do we go from it? And that's kind of the question that everyone has in mind. So post-thrombotic syndrome, as a recap, it's kind of the sequela of venous thrombotic process. As the clot sits in the veins, the valves get damaged, and what happens is, not immediately, but over time, meaning weeks to months to years, the reflux that happens in the veins causes a whole plethora of complications, including thickening of the skin, ulcerations, repetitive DVTs, pain, and so many other events that cause a significant decrease in the quality of life for these patients. Especially when they get venous ulcers, they become kind of a nightmare to treat. Resolving a venous ulcer, as we do wound care, it can take months to years, and sometimes that itself won't be enough. Getting patients to effectively wear the compression stockings when they have that severe disease is very difficult. Nevertheless, we need to find ways to treat those patients even in a chronic phase, but it'd be nice if we had a better way to treat them in the initial presentation to get to the point where we don't have to treat these situations. So when you look at post-thrombotic syndrome, you think about the venous circuit and where are the areas that we see it and where do we treat and what do we know? Well, we know that if we look at the iliofemoral system, those are the highest risk patients in terms of post-thrombotic sequela. The femoral popliteal area below the groin up to the knee, it's kind of that gray area. That's why there's a gray stop sign there. We don't really know. There's not a lot of great treatments for that. We know that we can intervene in those areas, but when you have a chronic problem there, balloon angioplasty is really all we have. People are trying stents and all that, but that's off label as far as we know. We don't have anything solid yet. So there's not a lot of great treatments once you have just isolated FemPop disease. So that's kind of in the middle risk area. And then calf vein disease, that's on the lowest risk in terms of PTS as we know. But for those of us who operate in this venous space, we know that calf veins are very important as an inflow source for having good outflow. So when we treat patients with chronic problems, we do need that inflow to be evaluated and made sure that it's optimized. Otherwise, the rest of what we do doesn't help. But the question is, what do we do about patients who present with these thromboses in these areas? You know, can we intervene or not, which is what the trial was about. So when we talk about VTE, we're talking about the whole combination of venous thromboembolism, which includes DVT, chronic changes, and PEs. The problem with this is it's very difficult to manage. We don't have great overall arching knowledge and great randomized double-blinded studies to tell us here's what works best here. We have so many of those for the arterial space, but not as much for the venous. So there's not a lot of great long-term options. And their other problem is that there's a wide skew of varying practices throughout medicine globally and nationally. Everybody has kind of a different practice pattern. There are a lot of people who have kind of a similar approach, but every case and how people approach it are so different that it's kind of hard to have a treatment algorithm for these. So when it comes to standard treatment for VTE, primarily it's medications, meaning anticoagulation, and there's a whole topic, you can have a whole chapter on that, and compression therapy. It's old age technology, but the uncomfortable high pressure, 15 to 30, 30 to 40 millimeters mercury compression stockings that go up to the thigh highs to the waist, that's still some of the best treatments we have for venous thromboembolism. They're not comfortable, but getting patients on these is what's very important, and keeping them long-term is the other part. They have to understand, even if you treat them, they need to wear these as long as they live, and that's reality. So what are the treatment options when we do something? We can do mechanical. We can do thrombectomy. We can do a combination of pharmacomechanical thrombectomy. We have just catheter-directed lysis. Some people use the ultrasound-guided with ECOS. Some people use just multi-side hole. And you can use varying different combinations. There's rotational mechanical thrombectomy devices, aspiration devices, and the whole gamut. So part of the issue is that we have so many different tools and how to use them. There's also no clear-cut way to know how to treat them. But what the trial said, let's take a look at patients with thrombus removal with lysis and compared to anticoagulation. So it was NIH funded, followed patients up to 2 years, and it randomized patients to anticoagulation or anticoagulation plus intervention. Now, that's kind of a little bit of an open-ended statement, as it's with intervention, meaning whatever you choose to do. Many patients had stenting as well in the study set. What were they looking at? They were looking at up to 2 years that post-thrombotic syndrome, and did patients, how do they compare between just anticoagulation or if they had intervention in terms of a post-thrombotic syndrome? They looked at reductions in severity of the PTS, the bleeding, rethrombosis, and death. So the trial had about 700 patients with proximal DVT, anticoagulation versus endovascular treatment. There wasn't a significant difference in PTS in what they found. They did find an increase of significant bleeding with the pharmacomechanical or the endovascular intervention side. It was between 1.7% versus 0.3 for the anticoagulation only. What are anything we gained from looking at the data further? Because initially it just felt like a big gut punch saying there's no benefit of doing intervention. And what we all understand is that's not truly the point. It's that they found iliofemoral DVT intervention had significant decrease in PTS severity symptoms and also increased quality of life. So that was something very important to understand from that. It's different for FemPop and calf, obviously, but that iliofemoral area is very important. The issue with the trial, part of it, and the way they had to run the trial and had to score and follow patients, that it was kind of binary in that you can't take a minor issue and say it's not significant. They had to consider all those significant. It was either that they had something or not. And that's a little tough when small issues in the PTS scale make a big difference in quality of life when it didn't really require anything further. So that made it difficult to say the patient was okay, but they had this minor problem that put them into the significant scale. One other issue that we have to keep in mind is a lot of the tools that we have in our arsenal right now was not available in that trial study set. And there's devices that no longer are used in the space. So that has to be taken into consideration when you think about all the endovascular treatments we have now, the tools we have, the techniques we have now. So that does make an impact. The other issue that many have thought about is that venography was the only way it was evaluated on the table as a completion standpoint. And I think we all know, or many of us know, that further adjunctive imaging with IVUS or other tools are very important to just say that you cleared out the vessel from a 2D image, and having further information to know that you clear as much thrombus as possible, as much stenosis as possible, is something that many of us employ nowadays, which is very different than before. So those are some of the thoughts on the analysis of the study itself. What did the results of this trial, which kind of we felt negatively impacted what we knew about this, it made it difficult to triage these patients. Around that time before that, we were saying, oh, we feel that when you have this kind of clot, we should definitely try to intervene. And we thought this trial would help us recommend that with our refers. But now with this information initially looking very negative, it made it difficult to have a discussion with refers as to why we should be doing something. And also with patients themselves, with media and internet, it's something that you have to be upfront and discuss with, but it's hard to explain all those subset analyses with them. So the ATTRACT trial kind of made us have to regroup and figure out how are we going to discuss these situations. What's a commonality that we all kind of agree on is that we mostly all, I think for the most part, agree that iliofemoral and iliocable, for that matter, thrombus needs to be treated, needs to be intervened on for the most part. All of them need anticoagulation unless there's a significantly strong reason why they can't have it and they need close follow-up. A lot of us choose to put on anticoagulation and then very short-term follow-up wise decide to intervene when things don't clear up. And that can be followed with CT venograms or MR venograms and ultrasounds, but ultrasounds doesn't really show you the iliocable space, which is why many of us will choose cross-sectional imaging. So here's a couple of examples of why treating these patients make a difference. This patient was 56-ish, has a history of cancer, prior DVTs and a filter during surgery removed, and then had red swollen leg. Left it alone, and their physicians kind of said, we'll just put you on anticoagulation, it'll be fine. Patients taking care of their family member at home, so it's very difficult to prioritize it, but if we had pushed for it, it might have been treated sooner. However, later on comes an unbearable pain, likely acute on chronic clot in the femoral and common femoral, and this is what we're dealing with. So now there's a strong chance if we had been able to address this in the beginning, we wouldn't be dealing with this picture on the table, which is where you have basically complete occlusion of the pelvic system and collateralized flow towards the IVC, as you see here. So we could have potentially avoided this had we intervened this on earlier, but regardless, we have to do something. So we go in, we intervene, we eventually get across. Sometimes we use pharmacomechanical, then we use balloons. And then you might have some clot residual, as you see here. There's some narrowing in the iliac. And then we eventually get a better result after aspiration thrombectomy was performed. the issue is, did we have to get to that point? Could we have prevented that chronic situation where now there's a strong chance that patient's going to come back again needing repeat intervention? So we just don't know. Another patient, PE DVT filter, has been off of anticoagulation because it was too expensive for the medications. That's kind of a fault of the follow-up and fault of everybody involved not keeping on top of this patient. Then, of course, comes in with worsening pain and swelling, and you're dealing with this. Pretty extensive clot. You can see there's a ratty appearance from the chronic stuff. So if we had treated the patient initially, you might not have had to deal with that. However, we're dealing on acute on chronic, which is never fun either. Sometimes in these cases, we'll do mechanical thrombectomy. The filter's there to protect it, and you are able to clear a lot, but this may or may not require 2 sessions, may have required lysis first, bring back the next day. A lot of us try same-day treatment. The point being that had we treated it the first time, we may not have to do this aggressively in a chronic state, which is still going to come back. You can't clear it all out, especially the hard stuff. So how do I approach this? First step, make sure the limb is not severely threatened. Make sure it's not a dangerous situation where you should intervene on it no matter what right away. And then the question is inpatient versus outpatient follow-up with anticoagulation. If they're going to be in the hospital for that or other reasons, then I get an in-house follow-up with imaging, see the patient, and see if it's not getting better within a short term, within a week, then you might want to intervene, and that's the right time. You don't want to wait till it's chronic because then it gets very difficult. Also, in many cases, getting hematology on board to help with the medications and to make sure we're not missing something that'll help us prevent them from rethrombosing or any other issues, especially in the family side. It's something great to have good colleagues in hematology. If they're very symptomatic and they have FemPop DVT and it's not getting better with anticoagulation, I will strongly recommend and discuss intervention because their quality of life significantly decreases. Even though it's femoral popliteal, clearing that out and letting the blood flow normally as long as the calf veins are good will make them better. And that's maybe anecdotally, we need more data to prove that out. But again, this is what each of us may do ourselves. Patients that I can send home, I recommend elevation with them, exercise, compression therapy, and stockings, anticoagulations. And it's important to teach them and remind them and your referrers that the anticoagulations don't dissolve the clot. That happens by the medications that we do intraprocedurally or through the catheters or when we do mechanical. That's where clot gets completely removed. It's not from just the anticoagulation. That takes a long time and it can't clear everything. And repeat imaging is critical. So why do I intervene? Again, we talked about phlegmasia, very symptomatic patients that also may have contraindication to thinners. You want to prevent fatal events and increase their life. You can reduce their hospital stays instead of making them stay miserable. You might be able to get them out fast. And that post-thrombotic syndrome, even 50% of people on anticoagulation will develop PTS. So if we can prevent that by half, that will be significant improvement. What about FemPop DVT? I mean, again, we're kind of stuck here. Not all of them need intervention. If there's ulcers, especially, I will consider intervening on them. Or if it's a GSV, we'll help with that too. But this requires discussing with the family, with the physicians involved, and everybody else. It's very important to have that frank discussion and show them what can happen if they don't treat it. And for us, even though the significant increase in bleeding in the study results, this is not something many of us have seen in real practice with using TPA or any of the procedures that we do in terms of a major bleeding event. It's just not something we see. So any other thoughts? So compression therapy, ultrasound follow-up. IVUS is an adjunctive tool which significantly helps us evaluate the vessel as a whole on the inside. We see stuff on venogram 2D images, but it's not really giving us the entire picture. So having access to IVUS really helps you solidify that you've cleared everything that you need to. Also, the nice thing about intervening with many of the tools we have now is you can do the same day intervention, prevent them from needing an ICU stay with lysis and get them out of the hospital. So having a same day option to get the patient out sooner is great for the patient, great for the system. And that's all I have. Thank you very much. And I hope you were able to get some key points out of this.